a compromised blood vessel, but you also are tearing up nerves. And if you tear up nerves, you could have a situation where somebody who was walking perfectly normally before may never walk again because they don't have motor nerves and they don't have any tactile sensation. So I actually think, personally speaking, I would rather take the time, stabilize it, and simultaneously push medications. I think depending on the patient and how they handle pain, very often you'll find that just simply putting a traction splint on will relieve the pain to a point where it's perfectly tolerable without medication.
And so two things I'd like to add. First of all, whenever I give anybody pain meds, I tell them straight up, this might help take the edge off, but it's not. Our goal is honestly, except for a few, maybe like cardiac chest pain. But other than that, we are not really in the business of taking away pain completely. We kind of take the edge off and do our best to make them comfortable, but they'll still be in pain. So obviously,
well, they don't remember it.
Right. So
which is the same thing.
Yeah. So, but no, I agree with Dave that if there's a mechanical way of relieving the pain, that's obviously preferable than pain meds, and it, can help them in the long run.
It's very, very quick to do. I mean, extremely quick to do. You can put an ankle hitch on. If you've got somebody on a backboard, so say for instance, you've got somebody that you're backboarding after a bike accident, and you put somebody on a backboard, you can put an ankle hitch on and put tension on. You don't need a Sega splint. You can get somebody tensioned up and stop the two ends of those bones rubbing together. And then once you've got them in the warm, away from, wet, cold gravel, then you can start worrying about being a bit more sexy about it from the point of view of putting all the goodies on. But you can just stick an ankle hitch on somebody and stretch the bones away from each other.
Mm-hmm.
And then bats are your best friends.
And you can tie it off. Yeah, you can tie it off to the end of the backboard.
Absolutely.
And I know both Dave and Jamie have a wealth of experience and knowledge, maybe, definitely more than I do as far as, having seen like pelvic femur fractures and stuff. But most of the ones that I've seen, other than like the little old lady that like falls in the shower or whatever, most of the ones that I've seen are like polytrauma. And so in my experience, I've typically just, backboarded them, and then that's addressed all, basically whole body splint.
Yeah. I mean, I've seen a couple like solo standalone femur fractures that I've actually, and honestly, I've used a hair traction splint. I mean, Sagers are nice, but I'm a hair traction kind of person.
Does actually having a femur fracture help? I had a femur fracture.
So here's a question for you guys. Can you use a Sager with both legs, on both legs?
Yes, you can. Yes. That is the benefit of a Sager splint.
Right. You basically put an ankle on each one.
So if you have a motorcyclist who goes over the handlebars and has bilateral femur fractures, right, that's your go-to.
So Wags, you actually brought up a real good question. Let's go back to the EMTs. What, besides mechanical, what pain relief can EMTs provide? It was an EMT protocol about 2 years ago.
Aspirin or acetaminophen?
No medication. What other?
Heat cold.
I'm sorry, what?
Back.
Okay, let's keep going. What other non-mechanical, non-medical, and we'll take ice pack as one, pain relief can you provide to your patient?
Pressure points.
Keep going. It was in your protocols about 2 years ago for EMTs.
Did you hear I said pressure points?
Yes, I heard pressure points.
Okay,
but this was a big topic about 2 years ago on your protocols. No idea, huh?
What about,
it's not cold. You're not talking cold. You're not talking pressure point, and we're not giving acetaminophen.
Right.
What about like being nice and like?
There you go. Now you're getting there. Talk to them.
I didn't know that counted.
Yes, that was one of our big topics for pain relief for EMTs.
I'm going to throw up a bullcrap flag. Pain still hurts even if you're nice to me.
You'd be surprised how many people you could change the subject and talk about something, about what, what, I don't know, where they live, what school they go to. You'd be surprised how all of a sudden, they still have that pain, but it kind of eases up. I mean, put the
I
kids.
don't know. I'm a firm believer in just giving them some normazoline and calling it a day.
Well, that's correct, but at the EMTs, we cannot do that.
Yes, you can. If you're an IV tech, you can.
Okay.
All the medics laughed at that, so they got it. I see everybody giggling. So
Right.
if anybody wants to know what I'm talking about, think of what I just said, normazoline. What does that sound like? It's normal saline all squished together in one word. So
Okay.
basically you throw an IV at them and give them a flush and watch how quickly some pain goes away.
Right. I mean, it's amazing.
However, don't report it on your
No,
report.
please don't.
Yeah, Jamie said so. Are there any other questions on the Sager now that we went downhill drastically on this one?
Yeah.
We're having a lively discussion.
I have one.
Okay.
I have one. When you have bilateral femur fractures, do you tension to the same tension or double the tension?
Good question.
Same,
Anybody want to answer?
same
Right.
tension.
Yep.
Yeah, same tension because the mechanism doesn't know if it's pulling one leg or three. It don't matter. It's just once you get to 15 pounds of pressure, you're pulling its max that you're supposed to pull.
Right. So just because they've got 2 legs, you don't pull 30 pounds. I've seen that done. It's not good. Don't do
So
that.
I have one question. Where is the Sager splint located on our ambulances?
Good question.
In the training room.
Yeah, the training room.
That's actually
In one of those outside compartments.
Actually, you guys will probably all get it wrong because we had a horrible time finding it too.
I got the answer. I'll send my driver out and they'll figure it out.
It's still not a good answer.
Yeah, your driver should know where it is before you ask for it. But
Okay, where is it?
Is it under the airway bag in the
Nope.
608?
Nope.
In the O2 compartment.
That's where it's supposed to be.
It's probably in a compartment by the trash can.
It's supposed to be in the right next to the oxygen bottle.
Is it there?
It's not. We found it.
All right, so where'd you find it?
We found it in, I want to say 607. It was in the compartment underneath the inverter.
So you found it in a whole nother ambulance. That's pretty awesome.
Yeah, I'll be honest with you, we're very concerned right now because there's not one on 608. There's not one in the pickup truck. There's only one.
Well, it's because in the past year, there have been several flyouts and DES has applied them and we never got them back.
Yeah, you lose them.
Yeah, so
Right.
we have to buy more.
So the big question is,
I guarantee you can go to any trauma center and they're not going to be there more than 30 seconds. Somebody's going to swoop it up. So
They're $350 a piece. Buy
Yeah.
more.
I guess I'll send an email to inventory for you real quick there.
I
Barry.
appreciate that.
That'd be a good one.
Totally appreciate that. That was a surprise to us. Thank you.
It might be a good one to order to have at least one on hand extra. So you got one on each ambulance and one extra, correct?
We should have won the training room anyway. We had 3 kids in the training room and we had 0 Sagers. We had a traction. I mean, traction.
4 or 5, Dave. How many do you think?
Well, we've got one that we know of.
We have 1 that
So
we
you
could find.
You should have 1 on each vehicle,
Right.
and you can get a spare.
What about Chase?
Well, that's what I'm saying. That's a vehicle.
Yeah.
So I'll say order 5, just in case.
Yeah, I would split that over a couple of months if I were you, just in case you're within arm's reach of Gannett when you send the order in.
Jamie, do you have one on your on your buggy?
I'll go look. Well, I know it's not underneath any of the pull-out trays, so I doubt it.
Okay.
It's not in the tray.
Right.
No.
But no,
I would order 5 over the next 3 months. How about that?
okay. All right. Can everybody see my next slide on KED? No.
No, I don't think your sharing's on.
Let's try this.
Reshare your screen.
Sorry about that. How about now?
Yeah.
Yes. Okay, so we're going to talk about the KED. The KED, unfortunately, is not used as much as it should. And as we're going along, I know Dave's going to help with this presentation because Dave, I understand you actually met the developer, Mr. Kidd.
I was trained for ALS because you had to use it during the National Registry Paramedic class. National Registry Paramedic test. And
Yes.
I went up to New Hampshire, and Mr. Kendrick came in and taught us how to use his device. So there you go.
Excellent. So as we go along, if you see anything we're doing incorrect, we checked a lot of different sources, and we actually have a couple comments at the end were ones that I don't think anybody knew until we reviewed it. Okay, so the KED. Damn it. Come on. Okay. What is a KED device? The Kendrick extraction device, called the KED, is designed to immobilize a patient found in a sitting position. It is most commonly used in an automotive accident where the patient is stable. If the patient is unstable, refer to rapid extraction protocols. The KED is designed to be used by a minimum of 2 trained providers. Additional help may be required. The load limit of the KED is 500 pounds max. The KED is always used with a cervical collar for C-spine control and always used with a backboard. As we go along here, so can anybody tell me why we would use a KED on a automotive accident on a patient?
When you have patients that are in the front seat of the car, or any seat of the car, it's easier to move them if they're experiencing pain in their back and you think there may be a back fracture, if you can immobilize them first. It's actually a very awesome tool. I love it. However, most times fire departments already yanked them out by one arm before we get there, so we rarely have the opportunity to use it appropriately.
So if we had a patient who had just had back surgery, say 6 months prior to their accident, should we use this?
Heck yeah.
Yep.
Yeah, your intent is to immobilize spine and neck completely prior to moving them to put them on a backboard. Because when you try to pull them out,
I would say as well, it's not just a matter of recent. I would say it's any history of back injury, because any history of back injury, you're going to make it worse, not better. It isn't going to get naturally better. So if you want to avoid the lawsuit, then I would definitely use a KED to deal with anybody who, when you do your interview, have you had back surgery or do you have a back injury? Yes. Okay. We're going to take the time to use a KED. And I know that you'll be the most unpopular EMT or paramedic within 50 miles, but it doesn't matter. Nobody cares. Just do the right.
We'll cover this later, but can you use a KED on a pregnant lady?
I would say that that's not a great plan.
Okay. You'll see.
You could.
I'll show the answer at the end of this slide. You would actually be surprised.
What you pull and where you pull it, I would say, is probably.
You'll be surprised. I was surprised till we found this out. Okay, so the KED. Here's a breakdown of the KED showing the different components. I won't go into each detail because we'll go through them as we're going through the slides, how to install this. Okay, so just as a quick review here, how do you fasten the buckles? You release the buckle, you connect the buckle in step 2, and you just don't pull the outer strap. You put both hands on the straps you see in this slide here, right over here, where one hand is actually pushing the strap while the other one's pulling the strap. You'll hear Mike Thrift talked about this quite a bit. The order for fastening straps by repeating the phrase, "My baby looks hot tonight." All EMTs, remember that in class? Yes, no? Wags, am I getting a shake of the head? Yes?
Yes.
Yeah, no?
They've added some letters to that. It was always my big toe.
Oh, I've always heard the other one. Okay.
I only used 3 letters when I was taught, man. You've added some stuff to that.
Okay.
I like "My baby looks hot." That's much better.
Yeah, that's a Mike Thrift one. Okay, so your first step is, of course, stabilizing the patient and attaching the collar. And once again, once you start stabilization, you do not let go till the KED is fully installed, just like a backboard. Step 2 is, once again, checking for PMS and documenting in your report you're finding. And you always check PMS before and afterwards. So step 3, you actually, now you notice we've let go of stabilization because I didn't have enough providers to help me do this training pictures. You lean the patient forward and you slide the kid down the back or from the side. So there's a lot of cars we could not do this. Obviously, if you had a headrest, you wouldn't have much luck doing this. So you can actually slide it in through the left or right side.
That's why you have firefighters, so they can cut the roof off.
Yeah.
That's right. They'll be happy when you say that.
I know they will. And then the insurance company has a conniption fit and starts asking everybody why they cut the roof off.
Just roll the top, man. Roll the top.
We didn't want to get sued because we put the cat on. There you go. Perfect.
Okay, step 4. So once again, you start with the yellow strap. You start the yellow strap first, the middle. Then you attach the red strap, the lower. Then attach the green strap, the upper. Now comes the difficult part. This is where you attach the leg straps. So you bring the straps underneath the legs, kind of do like a little scissor action to pull them, probably starting towards the knees and working your way back.
Can I stop you for a moment there?
Yeah.
You just stressed, just questioning, I don't disagree with what you're going down the path of here. Didn't you just say middle, bottom, top, head, leg straps?
Yeah, did I get it backwards again?
Didn't you do that in? No, I'm just saying, I thought we just went through that in the acronym.
No, my baby looks hot tonight. So middle, bottom, leg, head.
Middle, bottom, top.
Middle, bottom, top.
Head. Hot is head. And tonight is, see what I'm saying?
I think the H is hips.
Is it?
Yeah.
Because
yeah,
I didn't make the acronym up. I'm guessing that it's hips. That's what I thought it was.
Right.
I mean, I don't like the acronym, but I'm just saying, I think you're doing it right in the picture, but I don't think
the acronym leaves out the top strap.
There's always, if you watch numerous videos on this, which I did to make sure is right, sometimes they put the top strap on after the middle.
It's not that we're talking about, Barry. It's the head. We're having an issue with the.
So
that's right.
What I'm saying is there's times where you put the top strap on last, and depending on which training you watch, because I went through this quite a bit to make sure I didn't get it wrong, to make sure that I didn't have to answer these questions.
I'm going to, sorry, let's just stop for a minute.
Right, okay.
Middle, bottom, top is correct. There's nothing wrong with that. The issue that I'm having is the very last thing you do on a splinting exercise is stabilize the head into the splint, because otherwise anything you do anywhere else is tensioning the neck against the fastening that you just put on. So what I'm saying is, I'm not saying top, I'm saying head. The head is last. No matter what you do.
So Jeff Williams' class was middle, bottom, top, which means in the middle, your straps, middle, bottom, and top. Then tighten the middle, do the bottom, work the top. So middle, bottom, top, middle, bottom, top.
I agree with that.
I learned the same.
Okay.
That's right.
Okay, moving on.
I think Mike Thrift may be a little wrong in that instance.
Well, I think what he did with My Baby Looks Hot Tonight is, that's why I keep saying the H is hips. I think it was hips and then top is the head. And there's not H is head. It's the top is the top, your nugget. So I think the H was the hips, was his I don't remember that. I just remember what Jeff Williams, Chief Williams used to say was middle, bottom, top, middle, bottom, top. And then I was actually the herd that asked him, hey, why did you say that twice? He says, funny you should ask. And then he showed us middle, bottom, top on the straps, then middle, bottom, top, body, bottom, top.
I think that is a much better way of putting it.
Okay.
Okay,
so one of the notes here, the leg straps, we put them on as shown, but you can also crisscross them depending on which procedure, which set of instructions you watch. Okay. The leg straps are actually kind of difficult to put on.
I'm going to comment, sorry.
Okay.
That isn't the way that Kendrick designed it.
It's interesting because it came right off of Kendrick's website.
Okay, well, I guess he's died since then. So
okay, because there's good.
He has. He died. He's a very nice man. That's the way I know of doing it. But I guess when you're saying crossover, take the one from the back across the right leg left back, right leg. Is that what you're saying?
What you can do is you
Or-
can actually take the straps. So the one from their right leg, you connect to the left
Okay.
side, and from left side to right side.
Never seen.
That was in.
I was always trained, you take the straps on whatever side they happen to be on, you pull them down, go under the
Right.
knee, and then shimmy them back up to the hip
Right.
and reconnect to the
The
same
only reason I
side.
brought that up is that came straight from Mr. Kendrick's website when I went through to confirm this,
I,
because I knew there'd be a lot of discussions on
I've learned
this.
something. That's very good. So it doesn't actually matter what you connect up. You
No.
can't get it wrong.
So
Okay.
another little technique, excuse me, another little technique just to add is that like sometimes, especially with larger people who have, you know, heavier legs where it's hard to get the straps underneath, you can kind of almost saw them, you know, if that
Right.
makes like those you know, those little saws that have they're like the survival saws that have the little, you know, it's like a little cord and you kind of work it back and forth like that. You can almost do that same thing and just that way you can kind of slide the straps up.
Right. In fact, it's best to do it with your left and right hand. Have your left hand on one end of the strap and your right on the other, where your right's in between the legs. Like you said, you seesaw them back and forth to bring them in, because a lot of times they're very tight to get in. Okay. Okay, so now we're going to pad the head. So you always want to pad the void. And once again, you can see we've let go of stabilization, which we're not supposed to. You pad the void, you wrap the side around, and then you take the head straps and you attach the lower strap first, and then attach the head straps last. Any questions on that?
So
Just
the way
emphasizing no taping the head.
We won't get into that tonight.
I will take it every time. Ugh.
So just going through that again. So obviously in picture one, at that point in this process, that person would have his head stabilized.
Correct, that's what I'm saying.
And the way that you do that is you get your partner or somebody else to bring the flap up, and then basically as you slide your hand out, they continue to put pressure on the side so that you never release tension on the neck. And that's pretty important. That would be a fail point in a national registry test.
And reality, and like Dave was saying, an easy way to do this is have one person doing stabilization actually from the front in this case, so the second person can put the support in. And this is
slide your hand out.
right. Just remember, this is a two-person process.
I always had good luck at taking the pad and having the person hold the stabilization and then sticking the pad down from the top. So that way they didn't have to move their hands at all.
Right. So once again, you check for PMS and document in your report. Okay, so what do you do if the kid is too tight and the patient's having a hard time breathing? You immediately loosen the top green strap towards the strap to allow the patient to move, expand their chest. Keep the remaining straps tightened, provide stability for the patient during the start and stop of the process. Moving the patient to the backboard with the CAT applied allows, like Jamie said, allows you and easy to negotiate moving the patient to the board. You can tighten or loosen leg straps on the backboard as needed. And once again, you can loosen the top strap if the patient is for comfort, but retighten. So here was what I asked about. How do you put a CAD on a pregnant patient? I found this right in Mr. Ked's flyer. So instead of doing the side to side, you do the crisscross. Any comments there?
As a
I'm
recently pregnant person, no. I mean, everything that every physician, because I was like overly questioning of my doctors, everything that every doctor told me was that you do not apply any type of pressure strap across the abdomen of a pregnant woman because it compresses the fetal cavity and can cause undue stress on the baby. I mean,
okay.
Ugh, that's
But
just
this,
scary.
I'm not Mr. Kidd by any, or Kensing by anyway, but I would look at it as, does it still
It's
cross
not across
like
the
this?
fetus.
What I'm saying is you still cross, well, it depends. So some women carry high. So if you have a high carried pregnancy, that's directly across the fetus. If you have a low carry pregnancy, I could accept that. But Go ahead. I'm
That's why
sorry, Chief.
that's why women are instructed to put their seat belts below the baby bump,
Right.
because it's better to push up than it is to push down. And if you're putting straps across the top of the baby bump, then you're pushing down on the baby, and that can cause early preterm labor. So I don't know if I like that or not.
Could you
I wonder if it's like for early term pregnancies, like the picture almost makes it seem like she's not at term, like she's maybe, I mean, I don't know how many months, but maybe it's
Right.
short, early term, but late term, it seems counterintuitive to type of, I mean, I don't know, just my opinion. Seems
She doesn't look
weird.
pregnant. She looks like she's got a fupa. But
Right.
You put,
I mean, I'm
What-
not agreeing with you in that way.
what
As
is
I said-
what is the guidance then from you, Chief? So do you
Yeah,
want
because,
this
I mean, I
applied
took
or
this-
not?
I took this straight from the KED manual.
So you know what? Since I have my opinion and we have a KED manual opinion, I am going to do the smart thing, and I'm going to reach out to the authorities of our state and get you a direct answer.
Thank you.
How about that?
Okay. Because
And I would argue that, just for the hell of it, and I've never seen this done, I would argue that when you're in court being sued, then it's much better, you will stand a much better chance if you have the manual that you have got this from. So I mean, I'm sorry, but one does have to consider that. So,
Right.
if you've got a KED manual and it says this, and that's what you did, then there you go.
Once again, I spent a lot of time putting this together and researching to make sure, because I knew there'd be a lot of arguments throughout the whole presentation. So I tried to follow the KED manual.
Well,
I think
I would actually jump on board with you, Jamie, and find out what your guidance will be through the medical examiner or the medical director, because I mean, the King Airways got a manual, but I'm still not allowed to use that shit in the state of Maryland. Just because it has a manual doesn't mean the medical director gets to tell me
Wait
no.
a minute, that's you're talking apples and oranges there.
Is it? Because I
Yeah.
still have.
We are not authorized to insert an airway like a King as
Well,
a
that's the point.
an
That's the point he
EMT.
was making
There's
is,
plenty of
if you're looking at from a paramedic's view, I'm allowed to do a KED and a King, and a KED
Right.
comes with a manual and a King comes with a manual, but we only apply them in the way our protocols dictate, not the way the manual states.
And that's what my point is. So the protocol says that I can't do that in this state, but I can in other states, and it is an EMT National Registry required task. So the only reason I brought it up, I'm not trying to have this, a fight with any chiefs. It's just if it comes down to where there's a dispute, then either an operational chief says yes or no, or the medical director says yes or no. I think outweighs the fact that it's an EMT task that I'm not authorized to do.
So
See,
there's
unfortunately,
plenty of things that we use off-label. Like, for example, as Dave was joking around earlier, oral glucose, technically, the manufacturer would tell you you're not supposed to put it in an unconscious patient's mouth. But, it's technically an off-label use, something that's not necessarily endorsed by the manufacturer, but still authorized by our medical directors.
Funny story, we are the only state in the United States that has that.
But again, that still supports my argument then that the medical director's final say is what keeps me out of jail if I ever
well, then
go
go
into
back
it.
and look at your protocols. What does your protocol say about putting a KED on?
nothing.
Nothing. It says put a KED on.
Yeah.
Okay. Moving on. So adapting a KED for pediatric patients. Kind of an interesting topic. The patient's size and condition determines how the KED can be adapted to a child. So I'm going to bring this up here. This is very interesting because this came in once again the manual. So how do we attach a KED to a child? In this example, one possible method, the child's legs are longer than the KED, so the KED and the child are placed on a long spine board. A folded blanket is placed on the child so that the torso flaps can be wrapped and fastened normally and I'll show you on the next slide. So here it is applying a KED to a child while it's on the backboard. So they use a blanket in place there to fill the void. Any questions on that?
Just a quick note and search of the protocol. There is actually no protocol related to the Kendrick extrication device. It is not even listed anywhere in the protocol at all. Just FYI.
Good point. Good point. Here they showed stabilizing a hip and femur fracture and also the CAD at the same time. I'm not sure if I'd follow that. Storing the CAD. Like our next topic will be coming up on how to store spider straps. Everybody knows if you open up the CAD and it's just all thrown together, you're gonna go crazy. So your step one is turn the buckles under, fold accordion style, make the first fold, then secure the straps, just like in the picture in step 4. Wrap the leg straps, secure the folding straps in the fasten on the Velcro, and position the adjustable pad, which is used to pad the void, in the center. And then fold the torso flap, then fold the other torso flap, roll the CAD, and it's ready to go in the storage case. Any questions on that? Remember, always use a spherical collar if spinal injury is suspected. Always use a backboard and straps to transport. And now we got to practice. Obviously, we're not going to practice because we can't go in station and practice. Any questions or comments? I know we had a lot of questions on this one. Comments, questions?
I think we talked it all out in the class.
Has Andrew been modeling for the images there?
What's that?
Yeah, that does look like Andrew.
Andrew's got a night job modeling for the image.
You know, thank you. Oops. Thank you for bringing that up, Dave, because I've been blasted for not putting nice little cute pictures in. It does look like Andrew, doesn't it?
It does.
I kind of get it. I kind of get it.
You kind of get it? Okay.
I see it a little bit.
I see a little bit. Okay, so we talked about this the other time about how to properly, well, the question came up, how do you properly fold a spider strap? And the spider straps, of course, are used in backboarding a patient. Okay. Okay, so the first thing you do is you take your spider strap, fold it out on the floor or table, whatever's convenient, spread out just like you would have it on your patient. Line up all your straps so that they're not upside down. You notice how both the orange and the green straps, the Velcro is all on the same side. They're not on opposing sides, so sometimes you have to roll them. Okay, then you take your orange and your green straps, fold them in half. Now you start rolling the straw, rolling from the orange strap, rolling up towards the green strap. And you get to the top, you take your 2 neck straps, fold them, and you keep rolling. You end up a nice little bundle like this. Typically our spider straps have a little Velcro strap that wraps around to keep this nice and tight together. And I believe in some spider straps, you'll find actually a nice little pouch to put them in. I believe we have one left. I haven't seen many around. Any questions? Pretty simple, right, Jamie? Is that the right way? Good.
And Andrew's being used again for the
I knew you would say that.
Yeah, thank you.
You know, I had a better pitch, but I knew nobody would like it.
Since we're kind of on this topic, can we talk quickly about pelvic binders?
Yes.
I just wanted to
it's a good one.
So I recently read an article talking about pelvic binders and how they're actually underutilized. And so, you know, obviously, as we all know, the pelvis can hold a lot of blood before you even see anything. There can be, you know, 2 or more liters of blood in that pelvic area, and you won't even see any external signs when you assess the patient. So I'm a big believer in them, and I think we should be putting them on most blunt trauma patients, especially traumatic cardiac arrest. I think that's one of the things we should do empirically, even if there's no signs of pelvic injury. I think we should put a pelvic binder on. and based on some of the literature that I've read, it seems like we should be using them more, just in EMS in general, should be using them more than what the kind of status quo is right now.
Actually, Andrew, I'm glad you brought that up, because guess what? We need to do a little presentation on that, because a lot of people don't know what a pelvic binder looks like or how to put it on.
What do we carry, Barry? Do we carry both? Do we carry multiple sizes, or do we just carry the one size?
I believe we carry one size.
Because they come in multiple sizes.
Right, they do come in multiple sizes.
We have some amazing equipment in our station that we can use to make a pelvic binder. One of them being the SAM splints. You can
Right.
make it with a cravat. You can use just a cravat in general. There's lots of things.
Right.
I'm gonna pop the screen away from you, Barry. This is the protocol based off of pelvic devices here. So in the state of Maryland, indications for using a pelvic stabilizing device is evidence of pelvic instability on examination, patients complaining of pelvic pain, pain on iliac compression, and that would be on hip. The iliac is the hip.
Right.
Compression of the pubic symphysis, which is the front part, the front side of the hip right above the genitalia. Blood at the urethral meatus, so any blood coming out of the urethra, vaginal bleeding after a trauma, perineal or scrotal hematomas, or all blunt trauma patients with an unreliable physical exam and significant mechanism of injury may be considered. So if you have a nasty car accident and you cannot, determine pelvic stability, you can apply it at that point. It's contraindicated in patients for whom the smallest available pelvic stabilization binder is too wide and places pressure on the abdomen or chest, and children under 4'8" will generally not even fit a small size adult pelvic stabilizing device.
So this is actually a very good topic. So I know next week, Jamie, I believe we're going to go into some overview of bloodborne pathogens and also talk about the proper reporting procedures for the COVID. And then how about we go into the pelvic binder on our next one? It's kind of really cool topic. Ironically, just for a little bit of history. So the night before I was going to take my EMT practicals, I actually had a hip fracture that I had to install one. And my EMT that I was working with was arguing with me. And I said, this is a hip fracture. And she said, no, it's not. It's his cell phone in the pocket.
So this, you'll notice at the top of the screen here, this is an optional supplemental protocol.
Right.
So this is not statewide. So we need to make sure that Charles County is under the optional supplemental protocol for utilization of a pelvic stabilization binder device, which
So
I
Andrew,
will clarify with the JMD.
can we work on this, Andrew?
Yeah, I'd be happy to do that. I think, and I know this is a controversial opinion, others might disagree with me, but my firm belief is that a pelvic binder, in terms of a blunt traumatic cardiac arrest patient, a pelvic binder is more important than chest compressions.
Right. So I could tell you, so, everybody knows I run in 2 states. The other state I run in, they always use vacuum splints. So we just went to pelvic binders. And like Dave said, there's several different sizes, and we just put 3 different sizes on the units.